pediatric cardiac arrest, one pill can kill. And I told you at the very beginning of today's talk, not necessarily going into, 0.01 milligrams per kilo of a 1 to 10. It's going to be, what do we need to worry about in a normal everyday environment? Because these things can actually kill our pediatric patients. So something that was put out from the American College of Emergency Physicians, and this is like their accreditation, if you will, that looks over the emergency medicine physicians and their practices. So most of the PD poisonings are common and have good outcomes. And that's actually kind of interestingly enough because of how things are packaged. So, but if you're dealing with a prescription, and that prescription is something that is based on an individual that's, 40 years old weighing 200 pounds and a 5-year-old weighing 40 pounds gets it, clearly there's going to be a little bit of a difference in the way that that medication works inside that patient. So some pills that we're going to talk about have a very low dose, but they can be very, very deadly. And there's a poisoning in the United States about every 8 minutes. So a pediatric patient is poisoned about every 8 minutes in the US. So we have to have resources, and the objectives here, we'll talk about the prevalence and unintentional medication exposures. We'll talk some of the substances that can potentially be fatal to the pediatric patient, typically under the age of 6 or less than 10 kilos, and that's where they're coming up with the age. And then poison control, the number here, 1-800-222-1222. There are variations of poison control. This is a number that you should always be able to get somebody, but they're regionalized. As far as poison control is concerned, our local one here is Cincinnati Children's Hospital. There's another one in Louisville, which is our next closest. And those are staffed by pharmacists. So a pharmacist is probably who's going to answer that phone. And when they answer the phone, they're either going to know the information or have reference to be able to give you appropriate guidance on what you should do for your patient. I have used this. I said this last week. And interestingly enough, everybody's worried about the medical legal. So it's like, oh, if you're calling poison control, chances are they're going to tell you that you have to transport. And that has not always been the case in my findings. Contacting poison control, they've said, okay, just watch them for 10 minutes. If they have these signs and symptoms, transport. If they don't, then you're probably good. You can get a refusal and just have the parents keep an eye on them. So call poison control, make sure that you know the reference there if you need it. So calcium channel blockers. So these are household names: verapamil, diltiazem, amlodipine. Most of these are going to be used in the presence of a patient with hypertension. So not medications that are like way off the wall. These are found every day in households in all of our jurisdictions. Amlodipine for sure. Potentially fatal at 15 milligrams per kilo. And you'll see that this medication comes at 360 milligrams. So if you have a really small child that gets one of these 360 milligram doses, clearly you could work out the math there, but the mg per kg at 15, you could see that it would not take a whole lot of this if that patient weighs 10 kilos and it's, 15 times 10 is 150. Now I've got one pill that's 360. This is going to be problematic for the patient. The mechanism of toxicity here is myocardial suppression. It's not going to allow the heart to beat as effectively as it once did. And that is because of the hypertension. So the medication is actually working the way that it's supposed to work. It's just working in the wrong person. What you're going to see from a calcium channel blocker patient is that PR is going to end up prolonged. So your PR interval will get longer, greater than 0.20. So they're going to have a first degree block in whatever you're looking at. They're going to have Brady dysrhythmias that go along with that. So low heart rate. And that's because the myocardium is being suppressed. So that makes sense. And if the myocardium is suppressed and not functioning appropriately, then we're also going to have hypotension. So these are going to be very, very sick kids if they have in fact taken a calcium channel blocker. Tricyclic antidepressant. Everybody that has gone through at least paramedic school should be familiar with the terminology amitriptyline and Elavil. And that is because they always show up in national registry testing. As far as the potentially fatal dose, 15 mg per kg is what it's going to end up being. The highest dose available is going to be 150. So while it can be as dangerous, the highest dose is not going to be as high as what your calcium channel blockers are. So we would worry a little bit less. But again, these are very, very common medications, and they use them. They're called tricyclic antidepressants, but they may use these in headaches. So patients that have migraine headaches may be on tricyclic antidepressants. Patients that have seizure activity may be on tricyclic antidepressants. So there's a wide range of individuals that may be on TCAs, not necessarily because they're depressed. What are we going to find with our TCA poisonings? Seizures, tachycardia, and then ultimately coma, and then death is what's going to ensue fairly quickly. So seizure activity, if they've overdosed on these medications, for our purposes in the field, TCA overdose, if you're dealing with an adult patient for sure, what you should be looking for is the QRS starting to widen. If the QRS starts to get bigger, then we need to be thinking about giving them sodium bicarbonate. The mechanism of toxicity here is that sodium channel and alpha-1 blocker. So remember the sodium-potassium pump. This is how things get in and things get out. So if it's blocking those alpha-1 channels and sodium channels, our heart is not going to beat as effectively. The antidote here is sodium bicarbonate. Antimalarials, the chloroquine is one that you're probably familiar with here because all the COVID talk. It was hydroxychloroquine was one of the medications that has been kind of controversial on whether they should be giving it or not giving it. It is an antimalarial nonetheless. The potentially fatal dose here is 20. The highest dose available is 500. And it's sodium channel and then retinal damage as well. So with the retinal damage, you may end up seeing that they have vision loss. They're probably going to have headaches, maybe blurred vision, those types of things if they have any type of toxicity to it. And then what they're going to end up having is different from what the tricyclic antidepressants are. They're going to actually have a prolonged QT interval, which can end up leading to torsades and then VTAC, VFib, and then death. So if you remember back just going from the news alone, the hydroxychloroquine, it was showing real favorable, but there was a handful of people saying, well, we shouldn't be using it because it can prolong QT interval. Well, it's always done that, even when they were using it as its original intention. The opiates, you guys are probably very familiar with the opiates. So codeine, hydrocodone, methadone, and then fentanyl patches. But I just want to show you, you guys know obviously that respiratory concern, your CNS depression and the respiratory concern is what is going to be the biggest thing with your opiates. But look at your potentially fatal dose and the amount that's available. So codeine, 10 per kg, and the highest is 60. So we're probably going to be okay there. Hydrocodone, 1 to 5 and 30. Methadone, 1 to 2 is a potentially fatal, and it's 40. And then look at fentanyl, 1 to 2 mics per kg, and it's 300 mics per hour is how much these medications actually come. And I told this last week. I had a stepsister years and years ago that had medication. It was a prescribed opioid medication, and her child got it and ingested the medication and subsequently died from that. So these are definitely things that happen. It happened to somebody that I know personally. You've got to be careful, pay attention, and make sure that these medications are locked up. And not only the opiates, but all of these things, your blood pressure medication, especially if you have little ones running around there that don't know and understand what they're getting themselves into. Sulfonylureas, the sulfonylureas are your medications that you can think about for type 2 diabetes. So these are going to be glipizide, glyburide, metformin. Those medications are the ones that are used for your patients that have insulin resistance. So again, very, very common. You guys go out and do transports of patients even today, you're probably going to find somebody that is on one of these 3 medications for sure. Potentially fatal dose is 0.1 mg per kg. The highest dose available is 10 milligrams. And what it's going to do is basically drop their sugar. So it's going to activate insulin, which is going to cause them to become hypoglycemic. They're going to end up having seizures, coma, and then death from that. So what you're going to end up doing with these patients, if you truly think that they've taken a sulfonylurea, is you need to get a baseline glucose on them and make sure that that is trending in the appropriate direction and they're not dropping their sugar. If they are, then we're going to have to try to fix that by giving additional medications, i.e. D10, D12 and a half, whatever it is that you're wanting to use. And then your antiarrhythmics, this would make sense, right? So it's going to block the sodium channels like we talked about before, but procaine, lidocaine, any of those antiarrhythmics, the potentially fatal dose 25 per kg, they come 150 is the highest dose that it is available as far as from the pharmacy. And they're going to end up having EKG changes. So prolonged ECG intervals in the PR, the QRS, and the QT. So it is going to just kind of jack everything up with regards to their EKG, going to be very problematic for the patient. One final thing. When we're talking about medications, if you get a call for a kid that has ingested a medication, you kind of got to believe that, because we don't know what the untoward effects are going to be. If you get a call for a kid that has ingested bleach or gasoline or something like that, it is probably a very, very, very small amount, because they're not going to like the taste of it. They're probably not going to like the taste of the pill either, but if they get that pill in and it goes down the hatch before they realize what's going on, then you're probably in a different situation. So for me personally, I would put more emphasis in making sure that we're aware of what's going on with kids and pills than I would with other types of ingestions, unless they're old enough and they're doing it intentionally. You're not going to have a 5-year-old that's going to drink a whole lot of gasoline. They're going to spit it out and think that was a very bad plan from the very beginning. But if they're able to get one of these medications down, then you may be dealing with an entirely different circumstance. So the references from today are as shown on the screen there. They do still, just one other thought here, as far as charcoal's been removed, and it was weird because the K-beams would actually make you write a waiver request, and I had to do this every year. So we didn't carry it for a long time, and it was like, can we not just carry it and be done? No, you have to request a waiver every year. And then finally K-beam said, okay, well, we no longer even have to carry it. They do still administer this in the emergency department, but it's kind of few and far between. So it depends on how much of the medication they've gotten and what effects it's going to have on whether or not they're going to do charcoal. But for our purposes in the field, just be thankful that we're no longer having to do that.